Missing slides, but I will try to walk you through the management of aggressive lymphomas, at least how I approach it in this day and age. These are my disclosures. So with R-CHOP, when Rituxan was added to CHOP about, almost 15 years ago, it ushered in the new millennium. And after ages of just doing CHOP, we finally had something which improved progression-free survival and overall survival with the addition of rituximab. So how do we what have we been doing to improve responses based upon R-CHOP? So one is increasing the dose density, working with continuous infusion regimens, or adding novel agents. So as far as dose density goes, R-CHOP is given usually every 21 days, and it's been compared to giving studies where it's been used every 14 days with the hope that if you give it more often, that you will get rid of some of the you won't allow kinetic failure, and patients may do better. So there were two randomized studies from the French and from the British. But if you look at the curves, they're completely overlapping. There was absolutely no difference in overall survival or progression-free survival. And there was really no subset which benefited from giving R-CHOP every 14 days. Of course, everybody absolutely required growth factors to be able to do it every 14 days, but it didn't really impact the outcome. So R-CHOP given 21 days remained the standard of care. So we have all heard there was a lot of excitement about the dose-adjusted EPOCH-R regimen, which is a combination of about 5 drugs, but given continuously over a 24-hour infusion given for 5 days continuously. That changes the kinetics of the drug, and it's not only dose intense, but it's also dose dense. And at least when you compare historical data, on the left is what you expect with R-CHOP, a 5-year progression-free survival of 65%. In single-agent NCI data, the time to progression was 81%. So of course, the next logical thing was to do a head-to-head trial comparing the dose-adjusted EPOCH regimen to the R-CHOP regimen. And this was presented at ASH last year by the Alliance Group. And you can see, again, this was disappointing that there was no difference in event-free survival or overall survival in any subgroup. Now, molecular studies were not reported, so we don't know subset analysis of how many double-hit lymphomas were in this group, or how many primary mediastinal lymphomas was in this group. But for garden variety large cell lymphoma, even if it is the ABC type or we tend to worry about them more, certainly giving dose-adjusted EPOCH-R did not seem to make a difference. Now, you've heard about obinutuzumab, which is a glycoengineered antibody, and it is, at least in cell line data, appeared to be more powerful than rituximab. So that has also been evaluated in the Goya study, combining obinutuzumab with CHOP. So it's a G-CHOP instead of R-CHOP. And this was also presented at ASH. And again, it was rather disappointing that, again, there was absolutely no difference in outcome compared to R-CHOP, both for progression-free survival and for overall survival. So why are we getting all these negative trials? So as we learn more about the biology of large cell lymphoma, it's clear that it's not just one disease. There are many, many different subtypes. At the clinical level, we know that because outcomes depend on the International Prognostic Index. Patients with a high IPI don't do as well as patients with a low IPI. That's sort of a simplistic way of looking at it. But at the molecular level, too, there are enormous differences, and the outcomes vary according to the subtype. And this is this complicated cartoon which shows how heterogeneous the entity is. And even within the GCB type and the ABC type, there are a million different variations and permutations which can happen. So it's no wonder that there is a subset of patients who don't do well with R-CHOP. And just by adding something to that doesn't seem to at least be working as well as we thought it would. We also know about the emerging of the entity, the double hit lymphomas and the double expressor. And I'll go into this in a little bit more detail, but traditionally, when you have a double hit or a double expressor lymphoma, they really don't do well when you use R-CHOP. They tend to behave much more aggressively, and the overall survival, progression-free survival, is under 30–40% for the double hit or double expressors when R-CHOP is used. So based on the molecular understanding which has evolved in large cell lymphoma, there has been a revision to the WHO classification which actually reflects these changes. And now when the pathologist gives you a diagnosis of large cell lymphoma, it is recommended in the WHO classification that they actually qualify that into whether it is a germinal center origin or is it a non-germinal center, the ABC subtype, which whatever methodology is available at that institution, be it just immunohistochemistry using the Hans algorithm. At academic centers, we can do gene expression profiling, we can do the lymphocyte CX assay. So whatever is available at whichever center, do that, but at least do this because there are a lot of agents and a lot of clinical trials which are stratifying patients based on the cell of origin, so to capture the data in some way or the other. There also used to be an entity which used to be called B-cell lymphoma unclassifiable with MYC or BCL2 rearrangements. There's now, that entity is now called high-grade B-cell lymphoma with MYC and BCL2 or BCL6 rearrangements, but they have to also the pathologists are required to subclassify that as large cell lymphoma or a high-grade lymphoma unclassifiable based on the morphology they see. And if you can't classify it in any other way and it's not able to find any of the molecular markers and it looks very high-grade, it's only in that circumstance that it's called a high-grade lymphoma, not otherwise specified, which includes the blastoid features. Now, there are many, many targets which therapeutic potential in the non-germinal center large cell lymphoma, and you can see with the arrows that they target the mTOR pathway, they target the NF-kappa B pathway, the BTK pathway, then you have IRAK, and then of course you have the microenvironment, which lenalidomide. Now I can't go through each and every trial which is done, but I'll pick the ones which look the most promising. So the therapy based on cell of origin is sort of where everybody thought, now that we know at the molecular level that these entities are different, why don't we try to add an agent which targets a particular a pathway and add that to CHOP and see if we could improve outcomes. And there are 5 trials, out of which 2 have been the 3 in phase 3, and there are 2 which were phase 2 and 3, and didn't look that exciting either. Now, all roads lead to NF-kappa B in a non-germinal center large cell lymphoma, and it's the hallmark, and the activation occurs through a variety of mechanisms, and the proteasome inhibitor bortezomib inhibits NF-kappa B. So it was logical to add bortezomib to R-CHOP to see if one could overcome the poor prognosis because of the ABC subtype. So this was the US pyramid study, and it was pretty straightforward. They took patients with non-germinal center ABC, so it was a highly selected group of patients. They used the Hans algorithm, which was based on immunohistochemistry, and patients were randomized to bortezomib plus R-CHOP or just plain and simple R-CHOP. And this is, of course, was based on very good single institution phase 2 data, which showed that, at least in those small series, that patients who got bortezomib R-CHOP, the outcomes were better than historical controls. And so, of course, the question is, do historical controls comparisons predict results of prospective randomized trials? And unfortunately, you can see over here that there was no advantage to adding bortezomib in this trial, whether it was for progression-free survival or for overall survival. And even if you looked at it by IPS, there was absolutely no difference no statistically significant difference in outcome. So would this have been different using gene expression profiling instead of immunohistochemistry? Immunohistochemistry misses about 30% of the subtype classification. Who knows? Those studies are going on, and I'm sure we'll hear it at the next couple of meetings. There's a study going on in the UK called the Remodel study, which also is sort of similar. Everybody gets started on R-CHOP, and they, after the first cycle, they use those 3 weeks to look at the cell of origin using molecular studies, and then they are stratified. And all we've heard so far is the response rate, where it looks pretty comparable. We don't have any data about longer-term outcomes, progression-free survival, or overall survival. What about lenalidomide? Now, historically, adding lenalidomide to R-CHOP based on cell of origin has looked pretty promising. And if you look at retrospective data from the Mayo Clinic group, you can see that with R-CHOP, the outcome of patients with the non-germinal center phenotype is significantly inferior to the outcome of patients who have the germinal center phenotype. And when in a phase 2 trial they added lenalidomide to R-CHOP, this difference came together. So that means the patients with non-germinal center phenotype started doing as well as the patients with the germinal center phenotype, suggesting that this may be yet another way of exploiting the immune background and the interactions going on there. So this, of course, has led to 2 randomized trials. One is through ICAHO, and the other one is through Celgene, which is an international trial. We don't have results for any of these, but they have completed accrual, so we should be hearing more about the strategy. Now at ASH, we also heard about the REMARK study, where lenalidomide maintenance was administered after R-CHOP in patients 60 to 80 who had a grade 3B, DLBCL, grade 3B follicular lymphoma or transformed lymphoma. So this is sort of a maintenance strategy. And why was this done? Because in general, the transplant age cutoff is, in many countries, is 60. I mean, in the US, we tend to transplant them at 70, 75 also, but it's more performance status determined. So the general feeling was, this was a European trial, so that's why they used age 60 as a cutoff, that patients with age 60 to 80, if they have a if they have high-risk disease, if they relapse, there's not much more you can do for them after they've failed a Rituxan-containing regimen. So what if we gave those patients a maintenance strategy? Can we improve the progression-free survival or the overall survival? So that's exactly what they did. They took these patients, they got R-CHOP, and if they were in a CR or PR, they got randomized to getting lenalidomide maintenance or placebo. And you can see over here that there was a progression-free survival advantage for getting lenalidomide maintenance. There was no difference in overall survival. But what was interesting was that you would expect that the non-GCB group would do better, but in fact, most of the benefit was seen in the GCB group. So there's something weird about on this trial where it's very counterintuitive to what was expected, but in the subgroup analysis, it showed up a little differently. Ibrutinib, we are familiar with, is the BTK inhibitor, also has shown to be active in relapsed or refractory large cell lymphoma with preferential activity in the ABC subtype compared to the GCB subtype. And this you can see over here, 37% overall response rate versus just 5%. So this also has been taken to a randomized trial, the Phoenix trial, which was R-CHOP plus or minus ibrutinib. And again, we don't have results as yet. So it's fairly humbling to look at all the randomized trials which have done. I didn't touch upon the enzastaurin, the everolimus, or the bevacizumab. These were cold negative phase 3 trials. And I mean, I could go on and on and on about all the negative trials, but this slide summarizes all the attempts so far have failed. And it's really, like I said, humbling. And we really have to think as to why this is happening and find better ways to target these patients more appropriately. So I think at the practical level, what are the settings where regimens other than R-CHOP in this day and age may be preferable? I mean, by and large, for 80% of large cell lymphomas, nothing is better than R-CHOP, and that's what we use. But there are certain clinical scenarios where, based on the limited information we have or based on the poor outcomes with R-CHOP, it is reasonable to consider alternative strategies. And I've listed I'll walk you through these. One is very elderly or frail patients or patients with very severe cardiac dysfunction. HIV-associated DLBCL, primary mediastinal, double hit, the high-grade BCL lymphomas, and then primary CNS lymphoma. So, when you have very elderly patients, the options are several, starting from our mini-CHOP to non-anthracycline-containing regimens to even our bendamustine. And the our mini-CHOP was from the GILA, the French group, and you can see that it's basically almost like a 50% dose reduction on standard CHOP doses, and they capped the vincristine, they capped the prednisone, but nonetheless, the 4-year progression-free survival is 40% with about a 50% overall survival, and it was reasonably well tolerated. In a retrospective analysis from 2 institutions, we worry about giving an anthracycline regimen to an older patient, but when they looked at retrospective data, actually the patients who got non-anthracycline-based regimens, the outcome was inferior to those patients who got anthracycline-based regimens. So I think if the patient's cardiac function is okay, even if they're much older, using our mini-CHOP, which gives them some anthracycline, makes sense rather than not giving them. The only scenario where we don't use anthracycline at all is if somebody has a cardiac ejection fraction of less than 45%. Again, for HIV-associated large cell lymphoma, we know that Rituxan improved the outcome compared to CHOP, but there is data in a prospective trial which looked at dose-adjusted EPOCH-R, and it looks like the outcomes are better than R-CHOP, at least in the meta-analysis of about 1,500 patients. Primary mediastinal lymphoma is another entity which is primarily a disease of young females, and they present with this bulky mediastinal mass, and patients in the traditional treatment has been combined modality therapy, whether you use R-CHOP and radiation or use R-VCOP-P, MACOP-P, and radiotherapy with excellent results. However, given that it's a disease primarily of young females, the worry is about the cumulative long-term radiation-induced toxicity being second malignancies. So efforts were made like, well, can we come up with a regimen which you can avoid the radiotherapy? So that means increase the intensity of the chemotherapy. So dose-adjusted EPOCH-R is one such regimen, and this was initially developed by the NCI folks, where they gave it, and they had an event-free survival of in excess of 90, and overall survival in excess of 90% with a 5-year median progression-free survival. We subsequently contributed about 20 cases to this effort too, and our results were identical. So the data were pooled together for the initial publication. At ASH last year, we presented an update now with almost 100 patients, and the data are holding. And I think the main thing in this entity is that when you do a PET-CT at the end of the 6 cycles, if you have a Deauville 1, 2, 3, or 4, I think they do fine. It's only the Deauville 5s who get into trouble, and those are the patients you should actually biopsy. And if they still have residual disease, those are the patients who might benefit from going to salvage transplant or also considering radiotherapy at that point. But Deauville 1 to 4 do okay, and that manuscript is in press as we speak right now. But that's another regimen which seems to do better than just R-CHOP for this entity. Primary CNS lymphoma is another difficult situation because the traditional drugs used in R-CHOP don't cross the blood-brain barrier at sufficient levels. So you almost have to use a different backbone, and that backbone has traditionally been a methotrexate or an Ara-C backbone. So this one trial called the Matrix trial was presented, and you can see that they had 3 arms. There's been evolutions of studies. It was used to be just methotrexate Ara-C, then Rituxan methotrexate Ara-C, and they built upon that and added thiotepa. And patients, after they achieved a response, were then randomized to transplant or to whole brain radiotherapy. And you can see on these results that the arm which added Rituxan, methotrexate, Ara-C, thiotepa, and then took the patients either to whole brain radiation or transplant did the best as far as progression-free survival and overall survival. And there was really no difference between the outcomes of transplant or whole brain radiotherapy, but there were many more neurotoxicity effects, especially the executive function deficits seen in patients who get whole brain radiotherapy. So we try to avoid whole brain radiotherapy in patients with primary CNS lymphoma unless it's a last-ditch effort if they failed all the prior therapies. What about double hit or triple hit? These constitute about 3 to 10%, but it's higher amongst the unclassified in the prior classification. It can occur de novo, or you can see it as part of follicular lymphotransformation. So when the MYC is often a light chain or a non-immunoglobulin chain, and it can occur with complex karyotype also. And the true double the hits are of germinal center origin. So it's confusing just to remember the double hit versus a double expressor. A double hit is at the molecular level. The cell of origin is virtually always germinal center, and these patients have a translocation of MYC. with either BCL2 or BCL6, or if they have both, it's a triple hit. In contrast, the double expressor don't have the translocation. They just overexpress the protein on immunohistochemistry, and you have to be careful that the pathologists use the standardized cutoffs. So MYC has to be greater than in 40% of the cells, and for BCL2 in greater than 70% of the cell in the absence of translocations. And these are usually of the ABC subtype, and the outcome is inferior to other DLBCLs, but not as poor as the true double hit. So these categories of lymphoma also don't do well with just R-CHOP, and there are mainly retrospective studies from two consortium looking at this, and it suggests in both these data that the patients who get more intensive regimens such as EPOCH or Codox-M do better than if patients just get R-CHOP-like regimen. And this is for both the institutions. I think another evolving concept in management of large cell lymphoma is who to give CNS prophylaxis to. And traditionally, we've looked at the patients with, at least in the NCCN, it's patients who have Burkitt's or testicular involvement or epidural disease, marrow involvement. So the Germans looked at additional risk factors. They looked at kidney and adrenal involvement. So what they did is they added that as the sixth risk factor to the IPI. And if you had a high-risk disease, that means 4 to 6 factors, there was a 10% risk of failing in the CNS after getting R-CHOP-like treatment, so helping sort of choose yet another category of patients who may benefit from CNS prophylaxis. And these data were validated by the Vancouver group. So this then was looked at in the double expressor DLBCL2. So in the double hits, we know that they are more prone to CNS relapse. They sort of like, you think about it almost like a Burkitt's. In Burkitt's, we do CNS prophylaxis. So double hits also get it, but we really weren't sure in double expressor. So Vancouver looked at their data, and they looked at this modified risk, looking at the 6-factor score. And patients with high-risk disease, if they, and they had a double expressor phenotype, the risk of CNS failure was pretty high. If it's high risk was almost 18%, and for the intermediate risk was 13%. Whereas if they had low risk disease, it was only in the 2 to 5% range. So yet another subgroup, so if you have a double expressor, to think of CNS prophylaxis. Now there are many promising therapies under development, and you heard some of it yesterday by Dave Maloney about the CAR T cell, and you heard about the immune checkpoint receptors, but there are many others. There are BiTE antibodies, there are the JAK-STAT inhibitors, the BCL2 inhibitors, the EZH2 BET inhibitors, all targeting known aberrancies in the pathway, signaling pathways of large cell lymphoma. All these trials are ongoing, and hopefully one of them will come back positive where we can say, okay, the standard of care is going to change from R-CHOP. Encouraging data in primary mediastinal disease is with the checkpoint inhibitor. So there was data presented at ASH and then at Lugano with pembrolizumab in relapsed or refractory primary mediastinal lymphoma now. So this was largely a European study where patients had gotten Rituxan VCOP-B, which is the standard over there, plus radiotherapy. And you can see and had failed that, and you can see that in this small experience, the overall response rate was 40%, and about 80% of the patients had a reduction in lesions. So this also is now an international study for relapsed or refractory primary mediastinal lymphoma. In primary CNS lymphoma, we know that even upfront regimens don't have the greatest of outcome. And when they certainly fail an upfront regimen, they're pretty much doomed. I mean, most patients die within 3 to 6 months. If you look at the biology of primary CNS lymphoma, it's mainly the non-germinal center phenotype, and it also carries the MYD88 CD79B mutations. And both ibrutinib and lenalidomide are active in non-germinal center DLBCL. Both these drugs penetrate the CSF. And interestingly, the 9p24 alteration is also seen in primary mediastinal lymphoma. So of course, it brings up the question of the role of PD-1 blocking, which is dependent on that pathway. And there's been a fair amount of preclinical work on this. But this sort of puts together a table which looked at, 4 abstracts were presented at ASH, which looked at the combinations of either lenalidomide or just ibrutinib or even nivolumab in relapsed or refractory primary CNS lymphoma. And across the board, you can see that the overall response rate is anywhere from 60 to 100%, with actually even 75% of the patients achieving a complete remission with nivolumab. Now, the median follow-up is pretty short, but with the len-rituximab, it's about 19 months, and the median overall survival 15 months. With the nivo, it's about 11 months. It's certainly much higher than we have seen with radiotherapy or with almost any other agent, and meaningful CSF penetration of all these drugs was noted. I think if we be careful with ibrutinib, there have been cases of aspergillus reported, and one doesn't really know why. The question is, a lot of these patients are in concurrent high-dose steroids, and whether that predisposed them to aspergillus or not is unclear, but it's not something one should take lightly, and really watch out for this. So in conclusion, on initial therapy in 2017, I think R-CHOP remains the standard of care for most patients with previously untreated large cell lymphoma, with a 5-year overall survival of approximately 80%. The attenuated treatment regimens like R-mini-CHOP for elderly patients are very reasonable. Dose-adjusted EPOCH may be considered for some entities like primary mediastinal, AIDS-related or high-grade lymphomas and double-hit lymphomas. You can also use like a Burkitt-like approach for younger patients. Primary CNS is optimally treated with methotrexate Rituxan-based multi-drug regimen, followed by transplant in eligible patients. And of course, we have all the novel agents entering trials, and it's really important to enroll patients on these trials so that we can move the field forward. The future is also exciting because we know that while large cell lymphoma is curable in 50% of the patients, we don't know who's going to fail. I mean, so far there's been no test which helps us predict that. And is there a role, what should we do after frontline therapy? And there's really no clear benefit to surveillance imaging. I mean, after 2 years, we stopped doing scans on these patients, and really there's no data to support continuous imaging in these patients. So circulating tumor DNA in plasma has been demonstrated in solid tumors, and the question is, can we detect this in large cell lymphoma, and does this correlate with clinical outcome? So my colleague Ash Alizadeh and his lab looked at this, and they actually were able to find circulating tumor DNA. And this is just an illustration of a patient with a large cell lymphoma who had got treated with dose-adjusted EPOCH and then was in remission, but then had a scan which lit up. We were worried about, is this a relapse? Well, if you looked at the circulating tumor DNA, it really had come down really nicely, and they went ahead and biopsied, and it was granulomatous lymphadenitis, so it really wasn't a relapse. So the positive predictive value was very high, and the specificity is very high, but the sensitivity is still low. So there are studies going on to try to refine this procedure so that the sensitivity also increases. The advantage is it's, of course, not invasive. All you need is a drop of blood. There's no radiation. And it's much lower cost-wise than doing PET CTs on these patients. So do you get a lead time in detection of large cell lymphoma? And you can see these are patients in CR, and these are about 8 or 10 patients. And you can see that this is when clinical relapse develops, or you can see it in a scan. So there is about a 9-month lead time bias before there is this is the patients are in remission, and then this is finally at relapse. And there is about anywhere from 6 to 9 months before relapse is clinically apparent, where you start actually picking up the circulating tumor DNA. So I think all these strategies are being incorporated into trials moving forward, and we will be hearing more about them. So in conclusion, there are many new exciting agents. There are a lot of development of rational combinations with the goal of individualizing therapy. And I think it's really important to put your patients on clinical trials so that we can increase the potential for cure. And I think that is the last slide for the first talk, and I'm happy to take any questions. Thank you.
Thank you. I would like to have the questions now for this first talk, so we can move to the second after. Yes, Dr. Kumar.
Yeah, Shaji.
I think you have to turn on the mic. No, there's a... Or you can use this one.
have people looked at the impact of the GCB versus non-GCB in the pre-rituximab era? Have looked at just the CHOP alone? And it's the same difference?
A huge difference.
Okay. So it's not just the rituximab is affecting?
No, so huge difference, and the differences still persist in the Rituxan era.
Okay.
The differences are bigger in the pre-Rituxan era, but the differences are still statistically significant even in the Rituxan era. So adding Rituxan to CHOP hasn't really taken away the poor prognostic features of the non-GCB type.
Got it. Okay, thanks.
I have a couple of questions from a transplant perspective. Patients with a double or triple hit, we use these high-dose regimens, hyper-CVAD or other things. Is there any role for an autologous transplant as a consolidation?
So of course, there is no big trial to assess this. We don't know the subgroup analysis of the initial SWOG study, which looked at doing a transplant consolidation. At our center, if they have a double hit and they get a prompt response with dose-adjusted EPOCH, so they, PET negative after 2 cycles, we don't take them to transplant. But if someone has, had a very slow response and it's taken them 6 cycles to achieve a CR, those are the ones we would send to transplant. PR, definitely.
Thank you. The other question is that's what we see a lot in the academic setting. People referred after failing our CHOP, right? And, the salvage therapies, we often take them to transplant as a salvage therapy. Young patients often relapse after auto transplant as well. And so the question is, in these patients, would you consider other trials that you would suggest, or allo transplant? I know the Hopkins people have done a huge experience in haplo transplant as well for lymphomas with pretty good success. So what's your...
Again, the question is, so once you fail an auto transplant, the outcomes are grim. So you can, yes, before we had CAR T cells available or the bispecific antibodies, we have a lot of new agents which are new treatment options now compared to an allo transplant. Those patients tend to go on a clinical trial first before we would send them to an allo. At our center, we try to find kind of do it in parallel, because it takes about 3 to 6 months to find a match for these patients, and they can't really sit around with relapsed large cell lymphoma. So we either get them onto a CAR T cell trial or a bispecific antibody trial or an antibody drug conjugate trial. And depending, if it's just a localized relapse, we would radiate it also. And then if we, as they go, if we find a donor and they've gotten through those things or they relapse after that, they go to allo. But it's not a automatic first step for us.
For elderly patients with diffuse large B-cell lymphoma, would you prefer BR over R-mini CHOP or some other R-EPOCH, or do you have any preference?
So I think R-mini CHOP is much easier to give than EPOCH in an elderly patient. Also, that's the only published data there are with elderly, so the doses are pretty well defined. Bendamustine in large cell lymphoma, the activity is not terrific. It's not 0, but it's not as much as the 50%. We're talking about frontline over here. In the relapse setting, yes, bendamustine makes sense, but I think in frontline, I would still stick with our mini CHOP if you can give an anthracycline.
Sure.
If you can't give an anthracycline, we do what was published by the British Columbia group, substituting the Adria with etoposide.
Thank you.
Any other question? If not, get some water. Get ready for the second one. Yeah, thank you.
So switching gears to management of follicular lymphoma, which is what my original task was. Okay. So the objectives of this talk is to recognize the heterogeneity of patients with follicular lymphoma, discuss the various management approaches for early stage and advanced stage. That means the low tumor burden and the high tumor burden presentations, evaluate surrogate markers for survival in follicular lymphoma, and describe the emergent novel agents and optimal integration into treatment paradigms. Now, follicular lymphoma is a very well-defined entity. It's the second most common subtype of lymphoma, and approximately 30,000 new cases in the US every year. And it's the prototype of indolent lymphomas with a median overall survival of 15 to 20 years, waxing and waning course. And even in this day and age, it is incurable. It increases with age. The median age is in the 60s. And there is a risk of transformation over time. So if the longer patients live, they will experience some transformation in their lifetime. There's a lot of heterogeneity in this disease. At the pathologic level, you have grade 1, grade 2, grade 3A, grade 3B. And in the WHO 2016 classification, we've added a few other entities which come under follicular lymphoma. One is called in situ follicular neoplasia, and it used to be called in situ follicular lymphoma, and that almost led to a knee-jerk reaction for patients to get treated. And this is such a low-grade entity, and it's almost always an incidental finding. You know, a patient goes for something else, and the pathologist comes back with this. So the term was changed from in situ follicular lymphoma to in situ follicular neoplasia, with the hope that it will allow just watchful waiting and not have a knee-jerk reaction to treat. Similarly, the duodenal type and the pediatric type are also pretty well-defined entities. They can look pretty ugly when they present, but outcomes are excellent. And the duodenal type is often very just an incidental finding, doesn't need treatment. The pediatric type looks a little more aggressive, usually in the Waldeier's ring, but again, do very, very well with sometimes just excision alone. So just sort of, if you have these odd presentations, look it up before a reaction to treat. Now, there's clinical heterogeneity too. You can know from the FLIPI that there are at least three subgroups, and in the high-risk subgroup, approximately 30% of the patients fall in that subgroup, but with a 5-year overall survival is about 68%, and the median is approximately 8%. There's something called FLIPI-2, because the old FLIPI didn't take into account bulky disease. I mean, it only took, age, and you can age and number of nodal sites. So you can imagine that you have an elderly patient who's 75, has small nodes above and below the diaphragm in multiple places, 3-4 nodes, and has some anemia of chronic disease, and all of a sudden that patient who would normally, clinical judgment says, well, this patient needs just watchful waiting, falls into the high-risk FLIPI, and then there's a knee-jerk reaction to treat. So because of that, the FLIPI-2 was developed in the Rituxan era, and this actually takes into account even bulk of disease or not. And again, in that also approximately 30% of the patients fall into that group, and their overall survival is about 77%, and the median has not been reached. At the molecular level, this disease is also very heterogeneous, and you can see the gene expression profiling shows different immune-related signature, or with either a favorable outcome and or with a poor outcome. And this it's interesting because the prognosis based on that differs with therapy. So that data were published by Vancouver, and it was very significant, where in the training and validation set, that gene expression profiling, where CD163 is a macrophage marker, that the patients who had high expression did worse than the ones who had low. But then you give a more aggressive therapy than RCVP, and suddenly it has flipped. So as the biology evolves and therapies evolve, everything in the biology which we know with a certain therapy may not hold when you are changing your therapy. So we have to kind of reassess the significance of these markers as therapies evolve. So in 2017, where are we with follicular lymphoma, just as a baseline? Several studies now have shown significant improvement in overall survival. This is our data. We looked at over 1,500 patients with follicular lymphoma in our database, and we divided it into eras. And this era, with 2003, is when Rituxan was introduced. And you can see that in era 4, the median has not been reached. And even in era 3, the median was about 18 years, and this has not been reached. And I have, in the process of updating this data, we almost have an era 5 now, which is 2003 to 2014, where the median is it's not reached even for era 4, nor has it been reached for era 5, and it's well above 20 years. So the days where we used to say that the median overall survival of follicular lymphoma is about 8 to 10 years and tell our patients that's no longer true in this day and age. Many, many studies have supported this. And there are several new treatment options emerging, and the question is, how should these be incorporated? And I think because this is an incurable disease, the goals of therapy really need to be considered, not only in a physician's mind, but in the patient's mind, and to have an honest conversation with the patient so that you make a joint decision as to what is best for that particular patient, and not go by any knee-jerk reaction of, okay, just because the patient has follicular lymphoma, I'm going to treat the patient. So the key questions in early stage is radiation therapy the standard of care? For low tumor burden patients, is watch and wait or early intervention required? And high tumor burden who need treatment, is there an optimal regimen, and is there a role for consolidation or maintenance? So let's look at just stage 1. Both the NCC and ESMO guidelines They are single institution data, but the retrospective data suggests that there is prolonged progression-free survival in approximately 50% of patients with greater than 10 years follow-up. Of course, there's no randomized study, and the SEER data suggests that a third of the patients get treated with radiotherapy. And that pretty much is the standard of care in our institution. If the patient has truly stage 1 disease in a location which is easy to radiate, the neck or the groin, this is usually a disease of people in their 60s, we would do definitive radiotherapy. The LymphoCare study looked at patterns of treatment in a combination of community and academic centers, and a variety of entities were looked at, whether it was combined modality, Rituxan chemotherapy, our monotherapy, watchful waiting, or radiotherapy. And there really was no difference in progression-free survival and overall survival with all the different options for stage 1 follicular lymphoma. Now, even though it is said in the ESMO and the NCCN guidelines that patients should get radiated, in practice, the use of radiotherapy is going down in the community. And it's interesting because if you really look at all the data, the radiation-based strategies in these big in these big cohorts of patients using the SEER data, there actually is a survival advantage to using radiotherapy for early stage disease. This is combined modality therapy or radiotherapy alone versus observation or no treatment. The radiotherapy arm, this is not randomized, but at least from population-based study, it looks like there is some benefit. But it's sort of interesting that I think because of the fear of radiation, a lot of people have moved away from giving radiotherapy. And I just kind of want to put that, I'm not a radiation therapist, but a lot of the data about the late effects of radiation are based on outdated methods of radiation and doses and field sizes, which we would never use today. So it's not that all radiation is bad. The question is you have to use it in the right setting. Rituxan and radiotherapy has been used together. There's no randomized study, and it suggests that with either modality, the overall survival is excellent. It may be slightly better when you add Rituxan, again, a small series. And the other thing in radiation is the dose of radiation. So there has been a randomized study. Traditionally, people would use 40 gray as a definitive role for stage 1 disease. And if you actually look, the UK folks did a randomized study comparing 24 gray with 40 gray, and there was absolutely no difference in freedom from progression, progression-free survival, or overall survival. So the standard of care now, if you're giving radiotherapy alone as frontline therapy for stage 1 follicular lymphoma, is just 24 gray of radiotherapy, which is a much lower dose than what people are used to giving. What about watchful waiting in early stage disease? So we published, I think I published this when I was a fellow a long time ago, and we haven't seen any data since. We looked at about 40 patients with follicular lymphoma who for some reason or the other could not get radiotherapy. Either they refused, or it was in a location which was not amenable to radiation, like they'd had head and neck cancer before, or it was disease in the abdomen. Nonetheless, they were observed. And we looked at their outcomes, and the median overall survival was 90%. And interestingly, 2/3 of them never required any therapy with very, very mature follow-up. And the 10-year overall survival is 86%, 5-year 97%. And when we compared the watchful waiting to just even data from our institution, which used radiotherapy, there was absolutely no detriment to watching these patients. So even watchful waiting, if you have one small node which is not bulky, doesn't need treatment, is not an unreasonable option because they don't necessarily progress. And this, in our database, again, we looked at, does the improvement in overall survival we're seeing, is that only in the advanced stage patients, or is it also in the early stage patients? Well, it was also in the early stage patients. You can see, as in the advanced stage patients, in era 4, which is the current era, the median overall survival has not been reached, and the overall, across these 1,500 patients, the median overall survival is about 19 years for early stage disease. So it really is more like a chronic disease rather than something which is very aggressive. And this is reflected in the NCCN guidelines where all these choices I just discussed are all reasonable options. And again, radiotherapy is category 1. That means most of the institutions do that as practice. So moving on to advanced stage, I'm going to start with a case of mine, actually. It's a 52-year-old banker, totally asymptomatic, noticed a left neck node. And a biopsy showed grade 1 to 2 follicular lymphoma. Staging showed 1 to 2 centimeter nodes in the bilateral axilla, inguinal mesentery. The bone marrow is 30% involved. Labs are completely normal, asymptomatic, so stage 4A, low tumor burden. And he seeks advice from his local oncologist, and he's this high-flown banker, so he goes doctor shopping to various academic centers. He saw 3 US academic centers and 1 European academic centers, and all 4 gave different opinions. Okay, so these are the opinions he got. He got watchful waiting, he got single-agent Rituxan, he got single-agent Rituxan plus maintenance. Somebody told him R-CHOP plus Rituxan maintenance, and somebody said BR. So this is now a very intelligent banker who goes to 5 centers, has gotten 5 different opinions, and is trying to decide as to what the right decision for him is. He jets around the world on work every week, doesn't really particularly want to do something which he doesn't have to. On the other hand, he's scared. I mean, he has stage 4 follicular lymphoma, and he's 50, he has 2 young children. And so he ends up coming to see me. I mean, I think you can predict what I might have said based on everything I've said so far. So I told him this. And I'm going to walk you through the data. So again, this is the same data I showed you all, but looking at a subset, we looked at 1,500 patients where we looked at no initial therapy versus immediate therapy, and there's absolutely no difference. So in patients who who clinically don't need treatment, and we use the JELF criteria, and I'll show you that in a minute. So they're asymptomatic, low tumor burden, feel well, labs are normal. We watch most our patients, and watch doesn't mean never treat them. You just watch them and see them back in 3 months, 6 months, and if they need treatment, you treat them. But the first knee-jerk reaction is not treating them. And the similar data in the Rituxan era from the European, again, centers showing absolutely no detriment to patients who were either with watchful waiting or treated with Rituxan-based therapy. So I think there is enough data out there to show that there is no detriment watching the patient. What about so you worry, okay, I'll watch the patient, will the chances of transformation increase? Will their overall survival change? Again, this is in the LymphoCare study. No difference in overall survival, no difference in transformation. If you look at progression-free survival, if you look at how it's defined, progression-free survival, 1 is the time from diagnosis to the first treatment. And yes, if you've given somebody Rituxan or you've given somebody our chemotherapy, they are going to have a longer progression-free survival than someone you're observing. But if you really, that's sort of a bit of apples to oranges, because you're comparing someone who's been treated to someone who's never been treated. But if you take it to the time to the second treatment, so these are patients who you watched, and then they got something, and then they failed that something and got their second line, to patients who got something the first time and got then the second, absolutely no difference. So I think this should help make us comfortable that really not harming them by watching them. So this is how, there are many ways to define high-risk disease. We don't use the FLIPI, because FLIPI, while it's useful, it doesn't take into account bulk. And we find this much more clinically useful. A lot of the ICAHO trials and the European trials have used the JELF criteria to define bulk. And that is, you have a nodal mass greater than 7 centimeters, at least 3 sites greater than 3 centimeters, any systemic symptoms, B symptoms, splenomegaly, compression of a vital organ. I mean, you could have a small 2-centimeter node, but if it's causing hydronephrosis, you're going to treat the patient. So it has to be, something which is compressing something vital. A leukemic phase, so they have circulating follicular lymphoma cells, or they have cytopenia, suggesting that enough of the marrow is involved, which is also an indication for treatment. So looking at that, when you look at low tumor follicular lymphoma, the UK prospective study looked at watchful waiting versus Rituxan. And initially it was, a 3-arm trial, Rituxan and Rituxan maintenance. After the Swiss data came out and the other data started coming out, this arm was shut down. And basically this landed up being a study of watchful waiting or Rituxan plus Rituxan maintenance. And if you can see, there was absolutely no difference in overall survival or any transformation, even in this study. Again, like the previous study, the comparison of progression-free survival 1, yes, of course, the PFS will be better if you treat someone. But if you really look at it for the time to the second treatment, there was no difference even in this study. The ECOG resort trial looked at a different question. Everybody got treated with Rituxan, but then they were randomized to either getting Rituxan maintenance or just being observed and retreated if they relapsed. So everybody starts out with Rituxan. If they have a CR or a PR, they're randomized, put them on maintenance, 1 dose every 3 months, or just watch them and treat them only when they relapse. So, and if you look at those results, absolutely identical again. There was absolutely no difference in time to treatment failure, whether you did maintenance Rituxan or you gave them retreatment. And there was also no difference in quality of life. So it's not that the patients you are giving Rituxan to are feeling much better than the patients who you are just watching. So also the duration of Rituxan maintenance is very confusing. Some people say 2 years, some people say 1 year. The Swiss looked at 5 years, thinking, okay, maybe more will be better, and that's not the case. And this is data. They did include follicular grade 3. Some were untreated, some were relapsed. About 10% had prior Rituxan. Nonetheless, they were randomized given Rituxan every 2 months, and there were 8 doses versus up to 5 years. So basically, 2 years of treatment versus 5 years of treatment. And again, absolutely no different in event-free survival or overall survival. In fact, by giving more Rituxan, all they got was increased infections. So in 2017, for low-grade tumor burden advanced stage disease, the overall survival in recent data sets markedly improved. The median survival is greater than 18 years, and there's no impact of early intervention on survival or transformation risk. The short treatment with Rituxan can prolong progression-free survival, but there's absolutely no impact on overall survival or quality of life. And the clinical benefit of prolonged treatment with Rituxan is not really been established. And I think watch and wait remains a very acceptable option for low tumor burden advanced stage follicular lymphoma. And this is again reflected in the NCCN guidelines, where if there's no indication for treatment, it's a category 1. Most of the academic centers participating in the NCCN committee would also do watchful waiting. Moving on to high tumor burden follicular lymphoma. So we'll do another case now. A 62-year-old female presents with 1 month of abdominal pain, early satiety, well appearing but anxious. She has bilateral neck, axilla, and inguinal nodes, mild mid-abdominal fullness, and a CT shows a 10-centimeter mesenteric mass. And she actually has a biopsy of this mass, and the core biopsy is consistent with follicular lymphoma grade 2. She lands up having a PET, which confirms the findings on the CT, and this big mass in the abdomen with an SUV of 12. Labs are normal, except for LDH, which is mildly elevated. Now, it's important that, very often we tend to biopsy a peripheral node because that's very easy to biopsy. But if you have a CT or a PET CT which shows a big abdominal mass like this, it's really important to go and biopsy the brightest mass, also the biggest mass, because you don't want to miss a transformation. And sometimes these big masses are where the transformation is lurking. So don't just go by a peripheral node. You sometimes have to rebiopsy after you get the staging studies back. So what would you recommend? So this is somebody who has, is anxious, has mild satiety, has a mildly elevated LDH, but doesn't really have a whole lot of B symptoms. Is this somebody you could observe, or you want to do R-CHOP plus maintenance, BR or RCVP? And we don't have an audience voting system, but if you look, I just showed you the JELF criteria. This is somebody who has bulky disease, defined as more than 7 centimeters. And I think that in this patient would be an indication to treat this patient. And the question is, which of these choices are more reasonable? So if you just look at all the frontline regimens out there, there is an Italian trial which looked at R-CHOP versus R-fludarabine versus R-CVP. And what we learned is that the R-CHOP and R-fludarabine were certainly better than R-CVP, and the outcomes of R-CHOP were just as good as R-fludarabine, but much less toxic. So that sort of established that R-CHOP, at least in this trial, was the more reasonable way to go. The PRIMA trial looked at R-CHOP as a backbone, and they randomized patients achieving a response to Rituxan maintenance or no maintenance. And at a median follow-up of 6 years now, the data are holding that with Rituxan maintenance after R-CHOP, the progression-free survival is about 60% versus 40%, but no difference in overall survival. And they have seen increased infections in the Rituxan maintenance arm. And then, of course, the bendamustine story. We have 2 trials, the STILL trial from Europe and the BRIGHT trial from the US. The STILL trial showed these big differences with BR being superior to R-CHOP for progression-free survival, no benefit to overall survival. But if you look at the R-CHOP arm in the STILL trial, it's much more inferior than what you get in other trials. So we don't know whether this difference is so big because this arm didn't do as well. Nonetheless, the BRIGHT trial in the US showed that both these BR and R-CHOP for follicular lymphoma were pretty similar. So this difference wasn't as big, but the toxicity profile was different, and BR was probably a little better tolerated by older patients than R-CHOP, and then that way you can reserve the anthracycline for when the patient has a transformation. So these are all the regimens, again, listed in the NCCN. And you can give BR, you can give R-CHOP, you can give RCVP. They're all category 1 based on good randomized trials data. So what happens to this patient? She was started on R-CHOP outside and achieved a CR, and per the PRIMA trial was started on Rituxan maintenance. And about 13 months later, she noted a left neck and a right inguinal node, and she felt well, labs were normal. So she gets a PET CT, which just shows a left neck 4 centimeter supraclavicular conglomerate, and she has small, scattered, less than 1 centimeter nodes above and below the diaphragm. She gets a biopsy of this left neck mass. It's follicular lymphoma grade 2, but without any transformation. So what would you do now? So she basically has something which bothers her on the left neck, mainly cosmetically. It's been biopsied, it's low grade, and there's really not much more disease anywhere else. So can you observe this patient? Should you do radiotherapy? Should you give obinutuzumab? Should you give bendamustine because she's already had R-CHOP? Or should you salvage this patient and take the patient to auto transplant? So I can tell you, this is the stage which I saw the patient for a second opinion, and we looked at this, and this was not really an option for her because she kept touching this, and it really bothered her to know that she had a mass there. Nothing else bothered her because she really couldn't feel it. And I felt these were really overkill for somebody who has just basically one site of disease, which is low-grade lymphoma. So we opted to do low-dose radiotherapy to the left neck disease. And what is low-dose radiotherapy? I'll go to that in a minute. But if you look at the NCCN guidelines, again, if there's no indication to treat, observing these patients is also an option. Otherwise, it just loops back to all the algorithms you can do for follicular lymphoma, which is what that list was. So by low-dose radiotherapy, it's literally a total of 4 gray. It's 2 gray times 2. 2 gray given over 2 days, 4 gray. So that's really, really very low-dose radiotherapy, and it has excellent outcomes. We do this all the time for palliation for our patients with low-grade lymphomas. And you can see that in this study over here, the 4-year progression-free survival is 75%, and excellent overall survival in about 80%. And it's very, very well tolerated. I mean, they literally, even for patients coming from far away, they see Dr. Happy on one day, they get simmed that afternoon, and they get treated the next 2 days, and then they go back home, and we see them 4 months later. Very effective therapy, so keep that in mind. Now, 20%, so you can give them R-CHOP, you can give them BR, you can give them R-CHOP, R maintenance, you can give them RCVP. Across the board, what we're seeing is that about 20% of the patients will experience a disease progression within 2 years of chemotherapy. And that's the subgroup, that 20% of patients is considered a high-risk group who will relapse despite all these different approaches, including maintenance. So what is different about them, and what can we do about that group? So, and does that predict for survival? So the PRIMA trial, the French looked at that in their R-CHOP and the trial, and then it was, this is data from the US, presented by Carla Casulo from Rochester. Looked at patients who got treated with R-CHOP stage 2 to 4, and he looked at patients who get early progression within 2 years or who did not have any evidence of disease. And if you look at the LymphoCare study, or you looked at a validation cohort, you can see that the patients who don't relapse within 2 years actually do very, very well. Their overall survival is like 90%. But if they relapse within 2 years of their primary treatment, their 5-year overall survival is only in the 50% range. So suggesting that the 2-year benchmark could be a surrogate marker for overall survival, and that may be a subgroup where we would need to do something differently than what we're doing now. Similarly, event-free survival has also been, at 12 months, had a similar prognosis. And if you are disease-free at 12 months with nothing happening, your outcome is just as good as the general population. The expected survival is the same as a healthy person. However, if you have an event in that first year, then the outcomes are inferior. And this was seen in the Mayo Clinic SPORE, as well as data from the French in Lyon. Same data, that if you do fine for 1 year, your outcomes are just as good as the normal population. Whereas if you relapse within a year or have some event, the outcomes are inferior. Another surrogate marker is when you relapse, what is the relapse? Have you relapsed with follicular lymphoma, or do you relapse with transformation? And in the PRIMA data, we saw that if you relapse with follicular lymphoma, actually the survival is still pretty good. It's like in the 90% range. But if you relapse with transformation, if your first relapse is a transformation, then the outcomes are much more inferior. So this is a group that if you relapse with transformation, what they did is they took those patients to transplant. And if you look at the patients who went to transplant, the ones who went to transplant with just relapsed follicular lymphoma did not benefit from the transplant. However, if you go to transplant with transformation, that is a group which did much better with transformation. Sorry. Yeah, sorry about that. So if the first relapse is transformation, it's best to salvage that patient and take the patient to transplant. But if it's follicular lymphoma, they really don't relapse, the transplant is not necessary given the number of treatments we have for follicular lymphoma. Now, there are many emerging novel agents, and the question is how to optimally integrate them into treatment paradigms. And these are, some of the pathways you can see. And this is just a table we put together for all the trials which are going on and what are some of the drugs which are approved. And you can see that, I think this is out of battery now, but obinutuzumab and idelalisib are two drugs which are approved for follicular lymphoma, and I'm going to walk you through some of the data on that. So obinutuzumab is a third-generation type 2 glycoengineered anti-CD20 antibody, and it's improved preclinical activity compared to the type 1 antibody, which is Rituxan. Now, when it was compared head-to-head with rituximab in relapsed or refractory follicular lymphoma, there was no difference in progression-free survival or overall survival of these patients. But it's been looked at now in combination with bendamustine, and these data were updated and presented at ASH. And these were patients who had relapsed or refractory indolent lymphomas, but they had to be Rituxan refractory, defined as that they'd seen Rituxan within the last 6 months, so you wouldn't feel comfortable giving them Rituxan alone. So those patients were randomized to getting bendamustine plus Gazyva or bendamustine alone. And it's interesting that the dose of bendamustine alone was pretty high. Nobody, at least in lymphoma, we don't use 120. It's more of a CLL dose. In lymphoma, we tend to use 90. But nonetheless, if you look at the progression-free survival, my pointer is not working, but if you look at the events over here, at 6 months is when the curve starts splitting. And at 6 months is when the Rituxan, is when the maintenance strategy started also. So I don't know if this, let me go back. If you see over here the maintenance, so this arm here, which got bendamustine alone, did not get any maintenance, whereas the patients in the GB arm got maintenance. And right at about 6 months is when the curve starts splitting. So is this really all a maintenance effect, or is it truly a synergistic effect? It's hard to sort out. But an updated updated data which Chesson presented showed a survival advantage for the group treated with relapsed refractory disease. But again, with the caveats I've told you. So the Gadolin trial, the authors said that the GB plus G maintenance reduces the risk of death, progression or death, and demonstrated a significant improvement in overall survival. And their conclusion was that it's a new standard of care for relapsed or refractory patients. I think the caveats are, is Rituxan refractory definition, which includes a variety of patients, meaning clinically meaningful. So we know that somebody is Rituxan refractory for 6 months within the time they get it. But after 6 months, it's not that they're Rituxan refractory forever. And when you're giving them maintenance starting at 6 months, I think the arm which is missing on this is they should have done a Rituxan maintenance arm too. And that would have been the true test to see whether it was really the new antibody making a difference or it was just the maintenance question itself. And of course, the toxicity which they saw on the chemotherapy alone arm can be explained by the much higher dose of bendamustine used. And I think is the benefit of adding antibody to reinduction or effective maintenance versus no maintenance? Is maintenance or treatment at progression the preferable strategy? And how will these data be applicable now where most of our patients are getting bendamustine as frontline therapy? So, yes, it's of historical interest, this study, but it's not very practical because at least I don't see a patient who, for relapsed disease, who's not had bendamustine. Almost everybody I see has had BR before they would come and see us for a relapsed disease. So it's also been looked at now in untreated follicular lymphoma. This is the Gallium trial. So what this trial did is they looked at G chemo versus R chemo. So G chemo was interesting because it was dealer's choice. You could use bendamustine, so you could use BR, you could use R-CHOP, you could use RC, you could use CVP. So any of those chemotherapy backbones were fine, and you could combine it with Gazyva, or you could combine it with rituximab, and both arms got maintenance. So you either, if you started out with G, you got G maintenance. If you started out with R, you got R maintenance. And these data were also presented at ASH, and if you look at the data, in red is the G chemo arms, and the progression-free survival is slightly better with the G chemo than the R chemo, and the median hasn't been reached in both. So this was 80% versus 73%, and absolutely no difference in overall survival. If you look at the toxicity, the G chemo arm is more toxic than the R chemo arm. There's more neutropenia, there's more febrile neutropenia, and there were more infections. And I think more interestingly, the bendamustine containing arms, whether it was with G or whether it was R, had a lot of had more deaths than the non-bendamustine containing arms. And if you see, oops, I'm going the wrong way. Sorry about that. And if you see the all these dots, you can see that infections in the bendamustine containing arm are a problem, whether it's with the G drug or the Rituxan drug. And you can see that a lot of them start in the maintenance, maintenance starts at 6 months. That's about 180 days. And you can see that you see a lot more circles out there after the maintenance. So, I think it's sort of a learning lesson when a study is well designed and they're capturing this information, which may not have been captured in the STILL trial, that when you're using bendamustine as your chemotherapy choice, it is pretty lymphodepleting. And you're adding a strong antibody to it, be it Rituxan or be it Gazyva, you are causing more immunosuppression when you add maintenance. And there is many more infections when you have this bendamustine backbone. It looks over here that it's a little bit more with the G than with the R, but I think it's the maintenance issue when you use bendamustine as a backbone. And we don't use Rituxan maintenance after we've used bendamustine-containing regimen, because you do get into this problem. Interestingly, if you look at the minimal residual disease, the impact of giving Gazyva was seen mainly in the RCVP. So that's where the G chemo was much better than the R chemo, but everywhere else it was the same. So, you can also think about this. If you give weak chemotherapy and you give patients a stronger antibody, you will see a bigger difference. But if you use a good chemotherapy background, you won't be able to show as much of the differences. And interestingly, at Lugano, they presented an update on, how does PET do? So, whether you used R chemo or whether you used B chemo, if you were PET negative at the end of therapy, the outcomes were much better than if you were PET positive. So if you were PET positive with either, the outcomes were worse. And if you were PET negative, whether it was R chemo or B chemo, G chemo, the outcomes are terrific. So again, I don't think, we have not adopted this as frontline therapy, because I think this is a story which needs a little more dissection, and we would like to actually review the manuscript to see many more of the details presented. We've only heard it in at meeting presentations. So again, their conclusions was that it may be a new standard of care, and I think the caveats are the same as which I just pointed out. Idelalisib is also approved for patients who failed 2 systemic therapies, refractory to rituximab and an alkylator. The overall response rate is 57%, median progression-free survival 11 months. But I think the toxicity, the long-term follow-up, showing that the toxicity, that you can get infectious deaths, you can get the GI toxicity, the liver toxicity, has led to a lot of caution with this class of agents. There are next-generation molecules being looked at, but none ready for prime time. Lenalidomide is another option which is used, and again, the microenvironment plays a huge role in follicular lymphoma. And this is the CALGB study, which looked at comparing in relapsed lymphoma lenalidomide plus Rituxan, and you can see that the patients who got L plus R did much better than the patients who got L alone, and of course no difference in survival. But it has moved into the frontline setting, and there are 2 studies. One is the Alliance study and then the MD Anderson study. Both have a high complete remission rate. This is for frontline therapy with Len and Rituximab, and this is some of the data were updated at Lugano, and at the median follow-up of almost 5 years now, the progression-free survival is about 80%. So in considering follicular lymphoma, improving risk prediction at diagnosis, is there something we can do that to know that who might do better at diagnosis itself or do worse? Better understanding of the biology, which leads to this big heterogeneity of even within, like why are there some patients we can do watchful waiting and why are there some who need treatment? And then, of course, targeting with individualized therapy. So we heard about FLIPI-1, FLIPI-2, so now there is a molecular FLIPI, which incorporates a molecular signature along with a FLIPI, and that actually also performed better than FLIPI alone in high-risk patients and was able to tease out the high-risk group into actually a group which does quite well in blue versus the groups which don't do as well. And this was validated that it's also predictive of the 2-year progression-free survival, so that N-FLIPI performs better than FLIPI in predicting for 2-year progression-free survival. So again, this is something which we may be able to use at diagnosis to help us predict for patients who may not do as well, and those are the patients we should sort of design clinical trials for. Now, circulating tumor DNA at diagnosis is also another entity which is looking at predicting prognosis at diagnosis. So these are looking at it at baseline, is looking at the clonoSEQ assay, and they looked at FLIPI, bulk, beta-2 microglobulin, and only circulating tumor DNA was significant, where if you have a low circulating tumor DNA at diagnosis, the median overall survival is 15, progression-free survival was hadn't been reached, versus if it was greater than 40,000, the median was about 15 months. So that may be yet another test which may come in the future to help. So in conclusion, as we have new improved survival, we have new challenges. I think we have to consider endpoints for future and ongoing studies, evaluating the therapeutic strategies in follicular lymphoma. Quality of response is really important. Quality of life is very important. The ability to deliver second-line treatments. I mean, so if you hit your patient with the big gun right away, you do R-CHOP, you do transplant, this is a chronic disease. The patient's going to live for 20 years. Think of how you're going to manage this patient across their lifetime, not as a one-time thing. Long-term toxicities are important to consider. Cost. I mean, with the rising costs, this is not sustainable. And we have to really use wisdom to decide when and who we're going to treat with what we're going to treat, and actively engage and partner with the patient in all our treatment decisions moving forward. Thank you.
Thank you very much. It was a very, very clear and complete talk. So I have a question, though. After all the options that you proposed, a patient who's 55 years old with a bulk disease, but asymptomatic yet, not yet symptomatic. So big mass in the abdomen, but not yet symptomatic. What would be your first choice in this patient? We heard about R-CHOP or bendamustine Rituxan or now lenalidomide Rituxan. Looking at a young patient with a bulk disease, the possible future of.
So when how you manage follicular lymphoma is largely influenced by where you've trained. And if you were a SWOG institution back in the days, everybody was getting R-CHOP for that. If you were an MD Anderson, everybody got fludarabine. And if you were at Stanford, everybody, you start with watch and wait, because Saul Rosenberg was the big proponent of watch and wait. Now, somebody with such a bulky mass, well, I think one thing is clear, the patient needs treatment. So watch and wait is not an option. And because we know that patients do transform in their lifetime, and the most active drug in transformation is anthracycline, we tend to reserve our CHOP for relapse or when they have transformed. So in this day and age, I would use bendamustine Rituxan over our CHOP as first-line therapy without any maintenance. So lenalidomide and Rituxan, not for a scenario with a 10-centimeter mass. I don't still have the confidence that it's, I think of that more as like the patients who I would give single-agent Rituxan to, then it's better than doing single agent. But not somebody like this, I think, needs a little bit more therapy. I might at the end, if they're in, if they've had a PR, a really good PR, I don't necessarily switch the therapy to R-CHOP at that time or take to transplant. We would re-biopsy them if they've just had a PR, and if it's still follicular lymphoma, actually consider just radiotherapy to consolidate that area.
Yeah, I'd like to ask you about a case I have right now. A young woman in her 50s who was on the relevance trial, initially treated with lenalidomide and rituximab, who did not stay on the maintenance part of the study, and she works a lot and travels a lot and didn't like some of the side effects, and stopped it, but went through most of the therapy and had a very good response. I don't remember her initial stage, but she met the Guelph criteria to be on the study. Relapsed within 2 years with skin lesions. So a lot of nodules and some visible nodules and papules that were follicular lymphoma. She was then treated with bendamustine and rituximab and went on rituximab maintenance, and the nodules disappeared, but she then developed, she's now had an early just nodes in her neck, very small, but they've started to come back. And I'm interested in what your thoughts would be about our approach to her. She's in that high-risk category, appears to be, that you mentioned earlier.
Right, I mean, so this is somebody who's young, and this is now her third relapse.
Mm-hmm.
So this is this is somebody where I might consider talking to our transplanters too, because this is her third relapse. She's got, even though she doesn't have big volume disease right now, this is somebody, but nothing is holding her for long. Now, does that mean you've got to sort of tell her to put her life on hold and get transplanted immediately? Probably not. If these are small nodes in the neck and are not really symptomatic, she could, you could watch those. If it's really bothering her, like my patient with a 4-centimeter left neck mass, just to cherry pick 2 great times 2, just get rid of those lesions so that she stops focusing on them. But if you get more bulky disease or something, this is somebody actually who I would then talk to the transplanters about.
Okay.
You're a transplant.
That's actually was going to be a second question, is when would you
I think there's a
consider
risk
transplant?
of transformation at this point pretty high, so you don't know the next relapse what it's going to look like.
I mean, I'd
Okay.
biopsy every relapse. I mean, we don't treat without the biopsy. And
Yeah,
if it's transformed, I would definitely give anthracycline.
She's been biopsied. I have not biopsied I think we have done a PET, and it's not very active. This nodule she has right now hasn't been biopsied yet, but we did with the other relapse, the skin relapse. Now, why would you say the risk of, you think in that category, is it been shown that the risk of transformation is markedly higher, or the risk of progression?
No, we don't know whether it's a risk of transformation. We know that it correlates with overall survival. So
Right.
whether it's disease progression or failure of salvage regimens or transformation, I don't think we know that detail.
Okay.
But it's just that if there is an event, be it transformation, be it relapse with follicular lymphoma, there are several data sets which show the outcome is worse. In the PRIMA trial, those who relapsed with transformation did much worse than patients who relapsed with follicular lymphoma.
Mm-hmm.
That is but that's with after R-CHOP. And you can almost think that if you've already used R-CHOP, you're not going to be able to use anthracycline again. So so the outcome of patient who relapses with transformation will be less, because you've sort of lost the opportunity to use your best drug.
Okay. Thank you.
One more question?
Kenneth Deaton in Macon, Georgia. Just before I retired 4 years ago, I saw a 74-year-old woman with apparently a kind of a asymptomatic low follicular lymphoma, a few nodes in the neck, about 5% marrow involvement. But the conundrum was that she had mutations of MYC, BCL2, and BCL6. I did send her to Emory in Atlanta, and she was recommended to have chemotherapy, but she refused. What do you think of such a patient?
And she's doing fine.
Yeah, she was doing fine as when I retired.
So this is, the traditional double hit and double expressors have been defined in the context of large cell lymphoma. Okay, that's the group where we know they do badly. As we're testing these in every lymphoma which comes to the door, we're finding them even in follicular lymphoma. And it's always, I had a patient, actually one of the faculty members, a good friend, who had a groin mass and then, there's a panel which gets run by pathology, and it was MYC rearranged, and it was it was an overexpressed, not rearranged, and BCL2, and the guy was totally well. And I emailed around the country asking, my colleagues, like saying, okay, this patient is well. I would normally just treat this patient as follicular lymphoma, but does this bother you? And I think I must have emailed about 7 people, and Joe Connors was one of them, who was the senior most of the lot. He asked me, his question was, why did you even test it? So the answer is, I think if it's in the setting of a follicular lymphoma which has not transformed, I think I ignore it. If a patient is completely well and I treat the patient with how I would have treated the follicular lymphoma. But if it's in the setting where it's follicular 3B or it's in a transformed follicular lymphoma setting, then I would pay attention to it and treat it more as I would large cell lymphoma. But if it's just incidental finding with follicular lymphoma, I don't take that into account.
Thank you.
I think we'd be over-treating a lot of patients then.
Any other questions? If not, thank you very much. It's been fantastic. Thank you.